Okay, that worked. That was a great talk, Nani. Good morning, everyone. My name is Steve Monk. I'm the fourth year neurosurgery resident. This morning, I'm going to be talking about the cost utility of ambulatory spine surgery. It's really a continuation of my last talk. Back in the summer, I gave a very general overview of ambulatory spine surgery. This will take it one step further and look in a little more depth at some of the studies we've done in the past 6 to 8 months. So for a brief background, I don't want to go rehash everything I talked about in my last talk, but it's important to define what ambulatory spine surgery is. So from our standpoint, ambulatory spine surgery performed in a freestanding ambulatory surgery center. So these are facilities that provide same-day surgical care. It's very different from a hospital outpatient department. In the literature, that gets confused a lot of times, and a lot of studies will say they're doing ambulatory spine surgery, but it's really done in a hospital outpatient department. But those are very two different things. And so over the past 40 years or so, there's been an explosion of ASCs across the United States. Initially, that was mainly ophthalmology, general surgery. For the past 15, 20 years, spine surgery has really started to migrate to that setting as well. And there's a lot of reasons for that. And perhaps the most important is the cost savings that are associated with the ambulatory setting. It's really significant. If you look at these projections, this is just Medicare alone, billions of dollars a year. And the projections for private insurance is even higher. And so what we wanted to do is essentially say, these estimates are great. You can look at a payment schedule from Medicare. You can estimate if we move X percentage of cases from the hospital to an ambulatory surgery center, we should save X amount of money. But the question is, does that? So the way to figure that out is a cost utility analysis. So this is really the gold standard for healthcare cost accounting. And what it does is it allows us to compare two interventions on the basis of both cost and benefit. So cost is measured in dollars, whereas benefit is measured in quality adjusted life years. And we can plug those numbers into a formula that gives us an incremental cost effectiveness ratio. And that number essentially tells us how much money do we need to spend to gain one additional quality adjusted life year. And then we can compare that number to a willingness to pay threshold. That's from the societal perspective. There's a wide range of thresholds that you'll see in the literature. The initial number from the dialysis literature in the 80s, 70s, and 80s was $50,000. More modern estimates put that number closer to 200,000. And so any incremental cost effectiveness ratio between about $100,000 to $200,000 would be considered very cost effective. So what that cost of utility analysis allows you to do is essentially put two interventions into these 4 quadrants. And so the top left and the bottom right quadrants are what I call sort of no-brainers. So if an intervention is cheaper and gives you more benefit, then that's a no-brainer. That's probably a superior option. On the flip side, if it costs more and you get less benefit from it, it's probably not a good option. The incremental cost effectiveness ratio allows us to discriminate between two interventions in the bottom left and the top right quadrants, where maybe it's more effective, but there's an increased cost, or it's a little less effective, but it's also cheaper. And so we can use the ICER that we calculate, compare that to a willingness to pay threshold, and figure out whether that's an intervention we should be using. So those there. And so I put this up here not to, beat our chest and say, we've done all this, all these studies looking at ambulatory spine surgery, but I think it's important to know that before we started doing this back in 2015, 2016, there really was not a whole lot of data out there. Like I said in the beginning, there's a lot of studies that will talk about outpatient surgery, but these are studies that specifically look at patient populations that have surgery done in an ambulatory surgery center. And so non-CNSA studies, other than microdiscectomy, there really wasn't much out there. So we've, I think, done a very good job trying to demonstrate the safety, efficacy, and also the cost utility of the setting for spine surgery. So how we thought about going and doing that. So I think the first thing you have to do is you have to demonstrate the safety and the feasibility of performing these surgeries in this setting. It really doesn't matter how much money you can save if you can't do it safely. And so our goal was always to demonstrate that these procedures could be done very safely and very feasibly without a high rate of readmissions and reoperations that would offset those cost savings that we see on the front end. Once you demonstrate safety, then you can compare your patient population to a population from the hospital setting and make sure that those outcomes are similar. It's intuitive that they would be. You're using same instruments, doing the same surgeries, it's the same surgeons, but just like all of medicine, you have to demonstrate that in a study for that to be accepted by the general public. And then the last step is to perform a cost utility analysis. We know that you're going to save money up front. The question is, long-term, are those cost savings actualized? And so our first really foray into this was with ACDF, and I reviewed some of these studies in my last talk. But 2016 was the first study that we published on this. This was over 1,000 cases, our first 1,000 cases in the ASC, looking at safety for these patients. And we found that it can be done very safely, very feasibly. 90-day readmission rates were less than 2%. Inpatient transfer rates were less than 1%. Before this time, there was really nothing done on this topic. The two papers out there were hospital outpatient department ACDFs. So this was really a paradigm shift to showing that this can be done safely in the ambulatory setting. So despite that publication, there were still a lot of naysayers in the general public and even in the medical community that thought it was sort of crazy to be doing ACDFs in an ASC. And so a few years later, we updated our data with our first 2,000 patients and found similar results. Inpatient transfer rates of less than 1%, 90-day readmission rates less than 2%. And so we thought this was very convincing evidence that if you have a team that's bought in, you have very standardized perioperative protocols, that you can do this very safely and very feasibly. Unfortunately, Medicare in 2018 performed a review of their covered procedures in the ASC, and one of those CPT codes was 22551 for anterior interbody fusion. And so there was some question of, well, maybe you're having good outcomes because you're operating on young, healthy patients. And so in 2020, we went back and looked specifically at our Medicare eligible or Medicare patients, so patients who were 65 or older, and found very similar results that even in this patient population, if you select patients appropriately, you can still do ACDS very safely in an ambulatory surgery center. What we've done more recently is we've taken all that data. Now we think we've convincingly showed that we can do ACDS safely, we can do them effectively, but what is the cost benefit of doing it in an ASC? And so this is a paper we got published this past fall, comparing patients in the ASC to an inpatient cohort, and looking at the cost utility at 1 year post-op. So this was a retrospective comparison of 1 and 2 level ACDFs performed at our freestanding ASC compared to patients who had ACDFs in an inpatient setting from the QOD database. So all patients were prospectively enrolled, had prospective patient-reported outcome measures collected. There were about 6,500 patients initially in the study. We propensity matched those patients down to 748 patients. After propensity matching, the only significant differences between populations, there was a slightly higher rate of Hispanic and Latino patients in the ASC cohort, and as expected, or not surprisingly, a higher educated population in the ASC cohort. So what we measured, we looked at safety outcomes, so 90-day readmission and reoperation. We looked at patient-reported outcomes, patient satisfaction, return to work, and then we performed our cost utility analysis. So direct cost, we estimated using published facility fee data and professional fee data. For indirect costs were estimated using lost wages, and then we calculated an incremental cost effectiveness ratio. And so what we found was that ACDF, as we suspected, can be performed with equivalent safety in the ASC setting. So readmission rate of 3.2% from the ASC cohort versus 5.9% in the inpatient cohort. Similar story for reoperation rate, lower in the ASC setting. No significant differences and complications. So as far as outcomes, these are graphs showing neck pain and arm pain at pre-op, 3 months and 12 months post-op. So significant improvements from pre-op to 3 months that was sustained at 12 months, and no significant differences between the two cohorts. Similar story for neck disability index and quality of life. So significant improvements that were sustained at 1 year with no significant differences between the hospital or ASC setting. So our cost utility analysis, really the meat of this paper. So not unexpectedly, direct costs were significantly higher in the hospital cohort. The predominant driver of that is likely the higher facility fees that you get paid to perform these surgeries in a hospital. Indirect costs were similar between groups because they returned to work at similar rates. So you were left with a total cost difference of almost $6,000. Although there was a very small quality adjusted life year benefit for the inpatient cohort, when you plug that into your formula for an incremental cost effectiveness ratio, you get an ICER of over $3 million. And so whatever threshold you want to use, somewhere between $100,000 and $200,000, it's clear that $3.5 million is way out of that range. And so this was a very significant finding that corroborated what we expected to find. And that was for Medicare patients. For privately insured patients, that number was $8 million. And so we thought this was very convincing that ACDF, you can perform safely, effectively at significantly reduced cost in the ambulatory setting. Really, the next hurdle is lumbar fusion. And so lumbar fusion has been much slower to migrate to the ambulatory setting for a number of reasons. Perhaps the most important is this fear of inadequate pain control, that there's just no way you can get someone out of the hospital within 24 hours after doing a lumbar fusion. And even if you do, they're going to be bouncing back to the ER or to the hospital for pain control. Payer coverage is also important. So Medicare did not remove CPT code 22630 from their IPO list until 2021. So currently, only private insurance covers MIST lists in the ambulatory setting. So even though it's not on the IPO list, it's not on the ASC covered procedure list for Medicare patients. And prior to the data that we've published, there were really only 3 studies out there that looked specifically at ambulatory lumbar fusion, and the largest sample size was 41 patients. And so not good data out there to support the safety of this procedure. So this past December, we published our initial experience with this. So 2017, we rolled out a protocol to standardize how we manage these patients in the ASC to try to get them home within 24 hours. And our first cohort was the first 215 patients from 2017 to 2021. As expected, these patients tend to be younger, they tend to be healthier. Most of these patients underwent a single level T-lift. There were about 9% that underwent a 2-level T-lift. The important information to see here is that the transfer to inpatient setting, only 1 patient, so 0.5%, needed transfer for intractable back pain. And even though patients had the option of staying overnight, almost 3/4 of them went home the day of surgery. As far as 30 and 90-day morbidity, 3.7% rate of ER visit within the first 30 days, only 1 of those for intractable back pain. 30-day readmission rate less than 2%. Total 90-day readmission rate of 2.8%, and no reoperations within the first 90 days. And so this was really the first time that in a large series anyone had shown that MIS T-lift could be performed safely and very feasibly in the ambulatory setting. So the next step from that was to compare this patient population to a hospital cohort. So this study is in publication currently. So this was a similar study where we performed a retrospective comparison of T-lifts performed at our ASC to those performed in the inpatient setting from the QOD. All these patients were prospectively enrolled, had prospective patient-reported outcomes. Total patient cohort was 775 patients. After propensity matching, got that down to 200 patients with no significant differences between those cohorts. So this data is very telling. And so intraoperative complication, post-op complication rates were similar between cohorts, as were readmission and reoperation rates. So expanding on the first study showing that it's safe, it's feasible, now we've shown that these patients do just as well as patients who are similar but have surgery done in the hospital setting. These are the patient-reported outcomes, similar theme to the ACDF studies, significant improvements in ODI, EQ-5D, back pain, leg pain at 3 months that are sustained at 12 months with no significant differences between groups. So this is the next study that will hopefully be published in the next couple of weeks. So this is the cost utility extension of the MIS-TLIF paper. Similar story. So indirect costs are similar between cohorts. They return to work at similar rates. Direct costs significantly different due to those increased facility fees in the hospital setting, which gives you a pretty significant total cost difference, almost $15,000. Again, even though there was a very small quality adjusted life year gain difference favoring the inpatient cohort, when you compare that to the significant cost difference, you get an incremental cost effectiveness ratio of almost $1 million, which is very not cost effective. So these studies, this is a multi-year collaborative effort between multiple attendings, researchers, residents. And I think it's really important. It's shown that cervical and lumbar fusion can be performed safely with good outcomes and significant cost savings if done in appropriately selected patients. And this is really something that should interest everybody. Patients pay less, payers pay less, surgeons, there's the convenience of performing these surgeries in the ASC setting. And even for hospitals, sure, they're losing out on patients who would otherwise have surgery in their facilities, but then you're opening space for patients who really have to have surgery done in the hospital setting. So I think this is something that is going to be really important going forward and really hopefully going to drive some policy change and help us save money in healthcare. I just want to thank all my attendings, Dr. McGirt, Holland, Kim, Adamson, and Smith, and Hani. She's our postdoc research fellow. She's been really helpful in these papers as well.
Steve, congratulations on great work, and Matt and all the rest of your team that have done this work. This is really game-changing in this space. One of the things that's a competing interest right now, the system benefits so much from the inpatient margins that we're kind of riding that ridge. And we're doing the same thing in joint replacements because our biggest margin right now is on a hospital-based outpatient total knee replacement. That's, in the joint replacement world. But when that value switch flips, this is going to be incredible because then it's all going to be about your savings. That's where your margin is. It's not going to be in your revenue anymore.
Right.
So this is going to position CNSA and the system very well, I think, going forward.
Sure.
See, let me ask you a big picture question about database research. I know that Matt and Tony have been involved with QOD since day one and really the design of it. So as a researcher, when you're looking at all this, there's always the question that comes up depending on which data source you use. Obviously, the QOD has got a lot of functional stuff where if you just use like a Medicare discharge database, you're not going to get any kind of functional or quality or outcome measures embedded in there. When you do this research, though, with QOD, as well as it was designed, are there questions as a researcher you're like, I really wish we had that piece of granular data to make this a little bit stronger or more meaningful? Is there anything that that you wish you had data-wise, just elements from this type of database?
Yeah. So I think I sort of glossed over it, but some of those tables that compare EBL, length of surgery, things significantly favor the ASC setting, and the question is a TLIF really taking 3 times as long in a hospital as it is in the ASC? And I suspect no. I think it's probably quicker in an ASC. There's probably less trainee involvement. There's you're doing it in the ASC, to realize those efficiencies, you're going to have to be more efficient doing the surgery. But trying to figure out exactly what was going on in those surgeries. Was it resident-driven surgeries, or how was that data actually collected? In ASC, you may be biased towards having a lower EVL, shorter length of surgery, and in a hospital setting that may be recorded by circulating nurse, and you don't know when they actually mark the start time of surgery. It may be when they roll in the room. And so I don't think those are things that significantly change the conclusions from these studies, but it is something that when we've presented this at meetings and things, it gets pointed out.
Yeah. Matt, any other comments on that?
Sorry, I was just chatting with PK what a stud Steve was, but I wanted to comment just on something T said, which was the health economic landscape, and T's spot on about margins and competing interests. But one thing that's amazing in the value-based landscape and the contracting for payers is starting to switch a little bit more, particularly for one of the most expensive surgeries, which is like low back fusion. And, when a lot of these blue bloods are incumbents like Mayo Clinic or Duke, Hopkins, HSS, or, Cleveland Clinic, Mayo, are trying to shave 4 or 5% off their costs in this value-based landscape for inpatient fusion. When you can come in with 30% cost reduction because you can do it in a different setting, right? You can only shave so much off where you don't have a profit. But the greatest value-based evolution that I've seen in spine surgery to people who write checks is the transfer of setting like this. So we've been able to leverage this with a lot of direct employer contracting and some of our destinations. And so you can be a non-Mayo clinic and show up and out-compete them here in Charlotte when they're trying to give a song and dance a 5% cost reduction for their spine fusions, and you can come in at 70%. No one can compete with you. So I think that, as T mentioned, as we're evolving in spine surgery, if the world is cost containment, particularly of one of the most expensive surgeries in U.S. healthcare, which is spine fusion, it's inevitable that in 20 years, while this market is leading that effort nationally, that the rest of the world, and at least U.S., is going to follow. It's inevitable. Because if you figured out a way to do something at 70% of the cost, that the rest of the market in any field, it will evolve in this direction. So the biggest challenge, I think, through our Spine First Collaborative, OC, CNSA, Atrium-wide, is honestly to look at this case example of how to do that. Whether it's market share grab in our payer interactions team. So, and I'm sure the narrative is the same for the joints, and so that's sort of my take on I think what's been happening over the last couple of years. But the important point is not just doing it, but is creating valid data that demonstrates it in a fair way, and I think that's how you do it. So.
Did you use charges or reimbursements as a proxy?
We used the Medicare fee schedule, the published data.
And did you, we know there's a wide variability around those values. Did you guys do any sort of sensitivity analysis?
We did.
You did, and it dominated.
It did.
Can I say one thing on that? So the world of, as you well know, because you're an expert in it, but this world of health economics, private payer negotiated contracts are all over the place and proprietary. So what we negotiate in North Carolina with Blue Cross Blue Shield not only can change year to year, but it can be a half of what is in Chicago or a third in New York. So when you communicate this out there in the literature, one thing that's fully transparent is what the federal government will pay. And most every institution knows where they lie on a percentage of Medicare. So if one market's 300% of Medicare and another rural market's 150% of Medicare, you read the discussions of our papers, and we will give two values. What's an ICER, what's a cost benefit in national level at Medicare payment? And then in this situation, we pick a 250% or 200% Medicare as a example of a prior payer, even though we may be 300. And you read that and you say, you know, for your system in your community in Kansas, these cost savings will only be a third if you're at 200% Medicare or fixed. So it gives an anchor base so everyone can sort of understand based on their private pay costs, if that makes sense.
Yeah, makes great sense.
Yeah.
I was gonna comment on something you said about the travel patients that are coming because there's so much margin y'all created for the payers. I work with global healthcare, which is kind of behind the scenes, helping with kind of some of the concierge services for those patients. And it makes those discussions, the discussions that we have with the leaders of those employment groups that are sending patients to you, they love it. They absolutely love it. And there's room to grow on that as well. And so, you know, from a global healthcare perspective, we're proud partners. OC has some of the joint bundles. Y'all have some of the spine bundles with employers. And there's room to grow and support that from our perspective.
Steve, let me first a comment. You know, you had mentioned some of the answer to my first question, inpatient versus outpatient. You mentioned like residents and stuff like that. I think there's still huge value in this data because if you go to patient outcomes, you can reassure people and say, you know, if you're not eligible for outpatient or your insurance company or whatever it is, your patient-reported outcomes are going to be pretty equivalent. I mean, those graphs are all pretty similar. So whether there's a resident being the primary surgeon or not, and obviously they're not going to ask that question, but we all know that question. The outcomes are similar, and so that's powerful. The blood loss, is that really meaningful or not? The outcomes that are different may not be relevant. The question I have, and it sort of relates to both the comments that you made. So Matt made a good point that this shows an incremental 30% savings. However, going back to T's point about where the money comes from, what percentage of that 30% is just straightforward like hospital facility fees? Because if the savings in this is really only knocking off the hospital facility fees, that's actually not in the hospital's best interest to do that, because they're losing it out of their own pocket, even though the payers love it. Do we know what element or what percentage of those fees are facility fees?
So most of that is the facility fee, because the professional.
I mean, that's still the conundrum of that ridge that T is talking about. Is yes, you can knock a significant off. Yes, if you can change the paradigm for private payers, that's great, but it does hurt directly. So I would think that the government. Go ahead, Matt.
Yes, to that point, almost all of it, everything seems to be equivalent. The narrative is we can do select spine fusions in a low-cost environment without any detriment to quality and outcome. So that's the narrative. Your leg pain and quality of life return to work is not going to be better because the room's different, right? So that makes sense. So yes, there's a 30% reduction in what Blue Cross Blue Shield or what Walmart may or Amazon may pay. But the overhead expense is dramatically lower than the ASC. So the question is, if you're a hospital system that owns an ASC or hospital, what does that mean to the margin? So it doesn't go away. The $10,000 to $8,000 isn't all out of margin, because the overhead expense to manage an ASC is so much lower. What we don't know, because we haven't asked for it, I don't think we would get it from the administration, because not that that's wrong, is what the margin is. So it doesn't go all out of the margin. There's still margin. So I'm sure there's an inflection.
And a lot of it's new business.
Yeah.
These are the
volume
bundles,
play
right?
that comes in.
My point is that when you're playing fee for service medicine, you want the margin to be as high as it can be, and the system benefits from that. That's the point. In the value-based world, when you're dealing with bundles and capitated rates, then the savings is where the margin is. And that's why, as a system, you got to be invested in this, because ultimately that's what's going to happen. And that's where the system will win, in addition to the doctors and everybody else invested in the process.
But even
right now, it's a silly game right now, because it's about margin created from fees and from costs.
But even in the current model, a lot of this represents new business that's
out of region business.
Yeah.
People coming in the airport are traveling 150 miles
Yeah,
because
you
of
don't have
part
people coming in from 14 states for some of your bundles, right? Yeah. So there you go. That's good business.
To your point, you gotta have a reason in today's model to cannibalize your fee for service dollars. But when you're not cannibalizing and it's new untouched business, it makes sense to all players. So that's where we are to everyone's point.
Don't forget that each one of those that comes out of the hospital represents a bed that admits another DRG. It may be higher or than the spine. That's what the hospital administrators do not want to talk about whenever they talk about these cases leaving, is that you've got archer patients.
In a lot of discussions Steve did and we talked about, and we look at margins, part of our challenge with the bundle program as well as with those outside is looking at sort of the innovation and technology and how that's played an impact in spine surgery. And obviously there's a cost with that. And so this data that's been accumulated allows us now to look at subsets of these patients, different sort of technologies, all that have a price to them. Do they impact patient care? Is there value that we see that justifies the expenses involved with it? So those are things we've seen on some case study scales, but when we've got the ability to do the research that's been set up, databases that Matt and Tony have, and that Steve's been doing in our research team to really take a deeper dive and see what components of the procedure are modifiable, are essential. We see this on a smaller scale with our bundle patients when we have to make decisions on implants, navigation, robotics, and all of those things we'll see on a bigger scale and how they make a bigger impact in our patient care. So a lot of exciting stuff. This is foundational for it.
A quick PSA for Dr. Wade and Dr. Scannell. So when you're filling out your ACGME survey, both attendings and residents, yes, you get formal teaching and cost effectiveness. I think a lot of programs got dinged on that last year, but I mean, this is what this is. This is understanding how you make choices and how you improve the economics of what we do.
For the residents in the room, those of us who've been other places in the country, there's nowhere on earth that gives the real life cost of medicine, how to run a business, how to operate outside the ivory tower, like what the programs do in Charlotte. Definitely in nursery, there's nobody close to this. Orthopedics is similar.
Absolutely.
Great talk, Steve. Donnie, it was a wonderful talk this morning. Thanks, everybody.
Matt, you said blue one, almost pissed my pants. That was hilarious. Just so you know.
Yeah.
Oh.